very attentive, given the fact that this is immediately post-lunch, right? So, are you all set? Can we start with the first question, or you still have some takers? Just a minute. No problem, no problem. No, take your time. Done? 96 clears. 96, wonderful. Okay, I'm waiting for our latest colleagues to kindly take your places. Okay, so I'm going to flash a question and the related visual. If there are some clarifications which I need to do, I'll do it. And then I will say, please vote. From the time I say, please vote, you get 15 seconds, right, to make your decision and press the appropriate choice. And after that, we get the graphics of the vote distribution. And then we'll go to how to crack the answer, which is the correct answer will be displayed there, and we'll go to the correct answer and sort out why. After we've sorted out that, we move to the second. So I've got 10 sets of questions here. So we'll start with question 1. One of the titles is not appropriate. That means 3 of them you can use for the pathology shown in the clip, except one term. One term cannot be used. You have to choose that term, right? You can start voting. Wonderful. So we have 42% who've got D. But we've got 32% who said yay, right? So D is the right answer because D is flashing in green out there. Sinus venosus ASD is a very, very rare form of VSD. And it is seen only in a long section which passes through the IVC, SVC in a coronal fashion, which we do not do in practice. Sinus venosus VASD is something which is a part of total anomalous pulmonary venous drainage. It's an association. Whereas what is seen here is loss of offset of the AV valves, and the drumstick or the septum primum is detached from the crux. Agreed? Septum primum is detached from the crux, and that is a partial AVSD. Ostium primum ASD, ASD type 1. All the 3 of them are synonyms. They mean the same. So the answer, the incorrect title is sinus venosus ASD, and I'm happy 45%, 42% of us got it right. Right. Now we move on to the second question. Simple, this morning's workshop. The structure indicated by the arrow is. You've got to choose the right choice. This is a mid-sagittal section. mid-sagittal section. Okay? You can start. Please vote. So B is the right choice, and B is 61%. Am I reading right? 51%. Oh, now in the morning in the mid-sagittal section, we said this is the roof of the third ventricle, and that is tela choroidae. And that is actually the floor of the space, subcallosal cystic space, roof of the third ventricle. Tela choroidae is the right answer, and half of us have got it right. Right. And tela choroidae has a specific pattern. It has a very abrupt ending, and that abrupt ending is due to, we discussed it in the morning, is due to the choroid plexus actually dipping down into the foramen of Monro. Okay, so we've finished the second question. Moving on to the third question. Here is the color Doppler of the venous X in the liver, the X configuration in the liver. I've shown you this in grayscale. I'm showing it to you in color. Now, looking at the color coding and the configuration, you have to choose which is the right diagnosis. DV agenesis, portosystemic shunt, persistent right umbilical vein, and umbilicosystemic shunt. Pay attention, yes. Pay attention to the color especially. We've got C scoring 39, correct? 39% have scored C. C is the right answer. And why is it right? I've got the normal X here, and normal X colors the same way. Both the limbs of the X are all the same color. It's blue or red, depending upon whether the liver is far side or the stomach is far side. Here you have the one limb of X in blue, the other limb is in red, and this is classical of a persistent right umbilical vein, right? Okay, we'll move on to the next one. That's a good green peak that we see there. We will go to question number 4. Which of these describes the findings in this video? There are two terms. Both the terms should apply. Your choices are TAPVC plus bradycardia, interrupted IVC plus bradycardia, TAPVC plus cardiomegaly, cardiomegaly plus AVSD. This is just to confuse you, but it's clear there's only one term, one choice in which both the components are the correct findings in the clip. Okay, you can start the timer. C has got, B. B is right, but B only 18% correct? Yeah. Now, the answer to this lies in the area behind the heart. Can you see the pulmonary veins are draining into the LA? Yes or no? Yeah, so your TAPVC and TAPVC A and C go for a toss. And in the same area, you see the descending aorta. To the right of descending aorta, what is this? What is this? The azygous vein, and the azygous vein is normally seen. But here, what has happened to the azygous vein? It is dilated. So that's azygous continuation. Azygous dilatation and continuation is a hallmark of IVC interruption. So the correct choice is interrupted IVC plus bradycardia. Yes, there is a heart block here. You have 2 times atrial contraction to 1 time ventricular contraction. So B is the right choice, and we have about 18% who've got it right. Interrupted IVC with bradycardia. Okay, this is question number 5. This is a high-resolution image of the lumbosacral spine. You need to look at the clip here and the still there. And before I let the time start ticking, I just want to show you that S4 is marked over here. Can you all see S4? S4 is here. And then I've got 2 arrows to help you. This is still, this is a clip. Your choices are dural lipoma, closed spina bifida, split cord, open spina bifida, tethered cord, closed spina bifida, myelocystocele, closed spina bifida. Your timing starts now. Please start off. Okay, so we have 63% who've come up with the right answer, and that's extremely, extremely great, good. So the choice is tethered cord. Now, why is the cord tethered? And that is where these landmarks are going to help us. Remember, in the second trimester, the last segment, sacral segment to be ossified is S4. So when you count from below, this is S4, S3, S2, S1. This is L5, L4, and you can see the spinal cord and the conus medullaris reaching up to almost the middle of L4. Any conus level below the lower border of L3 in the second trimester is tethered cord. You can see the skin continuity all along, which is there. It is not an open spina bifida, so the right choice is tethered cord and closed spina bifida. Right? So that's the right answer, tethered cord, closed spina bifida. Then we are halfway through. Let's move on to the next question, 6. Choose the correct diagnosis. Normal cardia, restrictive cardiomyopathy, dilated cardiomyopathy, hypertrophic cardiomyopathy, a very easy one. Your voting starts now, please. Yes, so we've got 79%. I said it's an easy one, and yes, you'll have agreed with me. And from a mile away, you know there's a cardiomegaly. From a mile away, the contractility of the myocardium is less. But that is perhaps generic for any cardiomyopathy. But what actually clinches the diagnosis is the enormous thickness of the right ventricular free wall, as well as the interventricular septum. They are grossly thickened. So your answer is hypertrophic cardiomyopathy. Let's move on to question number 7 now. And this is a clip. There are 2 different cases. The first panel is case 1. B is case 2. This is a transvaginal scan, a transverse sweep. The findings are seen here. Right? On the other hand, this is the coronal section of yet another case. And mind you, this is a coronal section. So that's the fundus. This is the cervix, cervical aspect. Now you have to get your diagnosis of A and diagnosis of B right. So the combination of A and B is the first term and the second term. Your choices are cornual pregnancy, eccentric implantation, A and B. Choice B is eccentric implantation and cornual pregnancy. C is cornual pregnancy and interstitial pregnancy. D is interstitial pregnancy and cornual pregnancy. Your time starts now. $28.4 have got A. I've got it right. But I thought more of us will get this right because I thought fairly simple. Now, the confusion is nomenclature. We all know what we are dealing with. Here, you have the left horn of the uterus, which is empty. The right horn of the uterus is gravid. But I cannot call it a horn because the connection is not myometrial. If you notice, it's just a leash of vessels, and then you have this bunch of myometrial wall there. So this is a rudimentary horn of the uterus on the right side, showing you a gestational event inside, whereas here you have a cornal section showing you a gestational sac within the uterine cavity or without? Within, because you can see the decidua going around. So this is a eccentric implantation. This is not interstitial. Interstitial is outside of the cavity in the interstitial part of the tube. So your right answer is cornual and eccentric. So A is the right choice. I'm sure most of you all would have got it, but some of you all could have had confusion regarding the terms. So the correct choice is cornual and eccentric pregnancy, right? So we leave this, go to 8. This also is an easy one. Here is a 10-week gestation. Choose the correct diagnosis. A, monochorionic twins with one twin showing selective IUGR. B, monochorionic twins with twin reversed arterial perfusion. C, dichorionic twins, SIUGR. D, monochorionic twins with twin-twin transfusion sequence. Can you start the timer, please? Or a lot of us have got option 4. Option 4 is wrong. Monochorionic twin TTTS is wrong. Now, what you need to carefully see is that this is a twin which has got its anatomy right. You have a head, you have a neck, you have a thorax and an abdomen. Whereas what is happening here is a small bit of tissue which is amorphous. Remember, both these fetuses have the same gestational age or different? Same gestational age, because it is monochorionic, and monochorionic means monozygotic. So both of them came from the same zygote which split. Therefore, both of them should have had this kind of configuration. Instead, you have an amorphous bit there, but what should catch your eye is the umbilical cord insertion of this bit. Now, this is pulsatile. Do you think it's a vein or an artery? That's the umbilical artery. Now, here the placenta is situated anteriorly, and so if this fetus were pumping on its own, what should have been the color of this? It should have been red. And also the fact that I don't see a FHR in the smaller one. In the clip that I've shown you, there is no FHR which is happening within the fetus, and this fetus is getting its blood in the wrong direction. That means it is obtaining blood from the placenta into the fetus, whereas the normal umbilical artery carries blood from the fetus into the placenta. So this is twin reversed arterial perfusion, otherwise called as a parabiotic twin, an acardiac, acephalic monster. So this is one of the earliest cases that I had in my collection. I thought this would be interesting. You have picked up TRAP at 10 weeks, and so we have to monitor it and maybe do a radiofrequency ablation or interstitial laser to block this supply off so that the load, hemodynamic load of this fetal circulation is not on the pump twin. This is called the pump twin. Now, this twin lives not because it has a heart of its own. It's living because its circulation is supported by the heart of this twin because of arterio-arterial and veno-venous anastomosis. Simple, it's TRAP. Question 9. Quintero staging of this case of twin-twin transfusion sequence. I'm telling you, both the fetuses are viable. This is a 3D surface rendering. You see one twin which is close to the surface, so to the myometrial wall. The other twin is seen here, which is much bigger. And you know, this also is moving if you notice carefully. So that also is moving. That is why I've said both fetuses are viable. Now, you have the fetal heart color Doppler here, and you also have the umbilical artery of the recipient twin shown to you here. So, given these findings, the stage of this TTTS is 1, 2, 3, or 4. Your voting starts now. So, stage 3, wonderful, 65, 66%, great. Now, why stage 3? Number one is both fetuses are alive. If one of them is dead and gone, it would be straight away stage 5. And you have a Doppler abnormality. You have not only mitral regurgitation, you have tricuspid regurgitation, you have a cardiomegaly which is happening, and there is absent end-diastolic flow of the umbilical artery in the recipient twin. So whenever both the twins are alive, you have an oligo-poly sequence. Instead of showing you the regular grayscale, I've brought a 4D, real-time 3D or 4D clip showing you that this is the smaller fetus. It has gone and stuck to one wall. Why? Because the amniotic membrane is tightly hitching it to the wall here. There is zero Liker, and that is why this fetus is unable to get out. It's trapped against the membrane and the uterine wall. So that is the recipient. That's the donor. The recipient, on the other hand, is larger, and it's got a lot of profusion of Liker here, polyhydramnios. So you have oligo-poly sequence. That is the sine qua non. You have to have that finding before you term it as TTTS, but because of the Doppler abnormalities, straight away it goes to stage 3, right? So I'm happy many of us have got it right. And the last question is, identify the marked structure in this 12-week fetus. I've just done slow flow Doppler of the cranium of the 12-week fetus. This is the head, this is the neck, this is the thorax, and I've marked one vessel here. The question is, you've got to identify this vessel. Superior sagittal sinus, inferior sagittal sinus, anterior cerebral artery, straight sinus. Your time starts now. Yep, expected. This is perhaps the best performance. This is really heartening. 90% have got it right, and this was, I thought, was simple for a radiology crowd, isn't it? Right? So you have the superior sagittal sinus here. You have the vein of Galen, the inferior cerebral veins, and the vein of internal cerebral veins and the vein of Galen here, and it continues as the straight sinus going to the torcula. And this, of course, is the anterior cerebral artery. This was very, very simple, but I thought I would put this because today, with slow flow technology, you're able to see vessels in a great detail earlier and earlier in fetal life. So thank you very, very much for your participation. Thank you. Thank you. Over to Dr. Sanjeev.
Thank you, sir. That was really absolutely wonderful. And we already have the winners. Just give us a few seconds.
Sure.
So we were giving 2 prizes, and we have a tie. So there's going to be just one first prize. And they are the ones with voting pad number 1919 and 66. Could you please come forward? They got 8 on 10 actually, both of them. I'd like to call Dr. Ramamurthy, please, to give the prizes. Yeah, it's been a wonderful show, really. Please forward up. Just let them introduce themselves.
Can you all introduce yourselves, your names and your institution?
The stage is yours. Come.
My name is Dr. Krishna. I am from Kashipur, Uttarakhand.
Kashipur?
Uttarakhand, sir. Uttarakhand. Yes.
Good evening. I'm Dr. Mansi Patil, DNB resident from Saifi Hospital, Mumbai. Dr. Mansi from Saifi Hospital, Mumbai.
Mumbai?
Yeah.
Wonderful.
But no ringing.
Yeah, I didn't get that many.
Wonderful. You can give the mic. Okay, ladies first. Please come here. God bless you. Keep doing well. And a wonderful career.
Thank you, sir. That ends Dr. Ramamurthy's session with us, and we will have him surely back again next year. I would request everyone to come forward and give their voting pads as we prepare for a quick lecture by Dr. Vishal, and then, of course, the demos.
Hello, पेन ड्राइव वरून होईल ना काही सर टाकून दे ना